Our next item, evidence-based prevention strategies, what works, will be presented by Ingrid Engene Gøranson. Ingrid is currently taking a master's degree in criminology and is also the General Secretary of the Association for Safer Drug Policy Youth Organization, Safer Youth. Don't forget that you can also send her questions through Slido, and after Ingrid's talk we will have questions for both Helge and Ingrid. Please welcome to the stage Ingrid Gøranson.
Okay. Does this work? No? Good? Okay, good. Okay, hi everybody. I'm so excited to be back here for a second year to talk about this very important topic, evidence-based prevention, what really works. Let's see if I can figure this out. Yeah? Okay, so first of all, what is evidence-based prevention? That is when scientific methods ensure reliable and systematic knowledge about the effects of preventative measures and interventions. That is, do we have an intervention that we know, that we have evaluated and we know it works the way that we think it's going to work? So does that really matter? We have a lot of intuition about what works. We have young people in our communities, and maybe we can see that they're heading down a negative life trajectory. So do we have time to find out, to look through peer-reviewed articles to figure out, does this really work? After all, like, we're all humans, we have experience from our lives. Does it matter? So this wasn't really the case when the Cambridge Somerville Youth Study happened in the early 1930s. At that point, they didn't have a whole pool of knowledge about what works when it comes to prevention, but they sure wanted to do something about it. So first I'm going to talk a little bit about the project, but I also want to mention that embedded in this, is a longitudinal study, which is very unique. So the goal of the Cambridge Somerville Youth Study was to prevent crime among and improve the life chances for underprivileged boys with problematic behavior aged 5 to 13. And this was going to happen by character development through positive role models. So this intervention, it lasted for 5 years. The kids that participated received home visits from social workers, and the social workers would advise the kids on stuff going on in their lives and also advise the parents on parenting skills. The children also received one-on-one mentoring from an adult role model that helped them in all areas of their lives. They received tutoring and homework help in order to enhance their educational performance. And lastly, they were involved in leisure activities and also summer camps to make sure that they had something productive to do in their free time and that their energy was channeled somewhere positive. So all of this, it sounds really great. It sounds like a lot of stuff that we're doing today. Intuitively, we think this is going to work. So, yep. How did it go? And luckily, as I mentioned, this included an embedded longitudinal study. So what they did was that when they recruited these boys, they were recruited by police officers, teachers, the church, social workers, and the researcher got this list with names. And then they made something called matched pairs, also known as diagnostic twins. So they got 2 children, and they were alike in many respects. For instance, maybe both came from single-parent households, maybe had the same socioeconomic status, same number of siblings. So in a way, you would expect them to develop kind of similarly throughout their lives. And then they flipped a coin, which decided either they're going to get the treatment, that would be the treatment group, that would receive all of the services, or they would be in the control group and receive no service whatsoever. So They did some follow-ups in 1948 and 1956. The children were now in their 20s. And surprisingly to everyone, the results was a resounding no effect. And this was really disappointing. Everybody thought this was going to work. They poured so many resources into this, and nothing. So many years later, in 1975 to 1979, a different researcher picked up this project. The children that participated were now in their 40s, and they wanted to see, okay, well, maybe we can see any effect back then, but how did it go now that they're in their 40s? So in this part of the study, she also asked all of the participants what they thought of the project, and they reported really good experiences from being part of this project. They said things such as, this was the best part of my life, and made unsolicited comments such as, if it hadn't been for the mentors, then I wouldn't have been such a good person, or I would have definitely gone to prison, and so on and so forth. So maybe after all this time, we could say that it worked, that it was well worth the money and the resources. Well, when we looked at the comparison of the treatment group and the control group, we could see that the treatment group that received the services did worse on all key outcomes. That includes, they were more likely than the control group to commit more than one crime, to suffer symptoms of alcoholism, to manifest signs of mental illness, to die at a younger age, to suffer from at least one stress-related disorder, and to report their life as unsatisfying. Their work as unsatisfying. Yeah. This is not really the point. I'll tell you one of the reasons why they think it didn't work, although it's like not the point of the rest of the presentation, but I'm sure you're curious. So what they're thinking now is that it had to do something with grouping together all of these boys who had problematic lives, who were troubled, and grouping together, they learned negative behaviors maybe from each other. So getting to know each other was that different effect. They wouldn't have known each other otherwise, and that's like the negative thing. So importantly, what can we learn from the Cambridge Summer Review study? First of all, it's never enough that something sounds like it's going to be a positive intervention, because the CSYS surely did sound like it was a great intervention. It's not enough to evaluate a project by asking the participants what they felt about the project. Because these boys, they really liked participating, but that's not good if your life outcomes are suddenly so much worse, right? So we need to do better evaluations. Thirdly, and very importantly, sometimes helping hurts. When you see young people and you see that this is not heading the right direction, maybe the intuition of a teacher, a parent, a social worker is, we need to do something. I don't care what it is, something is better than nothing. But that's importantly not true. Sometimes doing something is going to be worse than leaving the problem all alone. So, still, it's really important that we never waver in our commitment to prevention. Prevention is very cost efficient. Even conservative estimates indicate that we get a 10-time return on every single dollar we spend on evidence-based prevention. In addition, the prevention interventions that are evidence-based usually have the additional benefit of not only preventing substance use, but also mental health disorders, delinquency, low school attainment, school dropout, violence in families, and so on and so forth. So we need to invest here. So where should we start? Where should we look to figure out what is evidence-based and not? Luckily, we don't have to be creative at all. The UNODC, the United Nations Office on Drugs and Crime, together with the World Health Organization and experts from over 100 countries, have developed the international standards on drug use prevention. The second edition came out in 2018. And what these standards do is that they summarize all of the available evidence on prevention that we have today. And the goal is for member states, for practitioners, stakeholders, decision makers, policymakers, to look at these standards when they decide what kind of prevention systems we want. Importantly, the type of prevention that is covered in these standards is what was earlier referred to as primary prevention. So that means the goal would be to delay or avoid substance initiation. This does not mean that the UNODC and the World Health Organization doesn't think that harm reduction is important. They do, and they emphasize that regularly. So, what are some of the characteristics of the interventions in the standards? First of all, as you can see, also visualized here, the different strategies that work, they're implemented throughout the entire life course, from the infancy period into adulthood and into old age. It's also very important that very few of these interventions talk about drugs or substances specifically. It's not important to give information about drugs. What you should do instead is to address the individual's protective factors and reduce the risk factors. That includes, for instance, giving parents the tools that they need to be successful as parents, and for young people to receive emotional and social competence. Education, for instance. This is from the standards. So every intervention starts with a brief description of what the intervention is. It's followed by a summary of what kind of evidence we have for this intervention. And thirdly, and what is the most useful for us as practitioners, policymakers, is that for all of these interventions, there's a list of characteristics that are deemed to be associated with efficacy and effectiveness for the intervention, and also a list of what is associated with lack of efficacy or effectiveness or adverse effects. This is basically a do's and don'ts list. So there are many interventions, for instance, interventions in school when it comes to education, and that would be great if they followed the positive characteristics, but if they have some of these characteristics, it could be really bad. Okay, so the last point, are our prevention measures evidence-based today? So this is really exciting because yesterday I was at the launch of REPS, which is called the Review of Prevention Systems, which is a new tool developed by the UNODC. And the goal is to assess the level of alignment of national drug use prevention systems with the international standards on drug use prevention. So this spring, a pilot study has happened here in Norway, where a questionnaire was distributed by Chorus to different prevention providers here in Norway to figure out, is it evidence-based or isn't it? And as I said, this was yesterday. The report is not out online yet, so I have to apologize for the quality of these pictures. Okay, so first of all, if we look at the implemented interventions by quality, this one is split up into, for instance here, the evidence-based is only this tiny slice over here. So that means it's like this program has already been evaluated exactly this way, and we're doing it just the same way here in Norway. But it has been evaluated locally. This green section, about a quarter of the diagram, is strongly evidence-informed. So that would be, for instance, programs that looked at the standards and met many of the characteristics, but it hasn't been evaluated as it's been implemented here. And then worse is the weakly evidence-informed, the yellow section, 17% of the interventions. That means it made some of the characteristics, perhaps, but not all of them, and it's not very good. And then 25%, a quarter, is non-evidence-based. Interestingly, this entire section here, the supporting services, 33%, that is things such as offering daycare, leisure activities for young people, and mental health services. So this, importantly, they haven't been evaluated in terms of does this help preventing substance use? We think it does, but at the same time, since it isn't, it could have been, it could have been read, because this is important also here for the non-evidence-based interventions. There were some examples of interventions that were really interesting, but they were just not evaluated yet. And if they're evaluated, they could move up, right? So it's important that we do that too. So also for these purple ones, even though we like all of the stuff that's here, it hasn't been evaluated, so it could have been read, but also maybe it could just have been excluded entirely from the graph. And I'm just pointing this out because if we excluded all of the supporting services, even though they're really good, this red and yellow part would take up more of the cake, and maybe we would be a bit more worried than what we can see right here. Okay. This is sorted by the number by age and quality. And I want to point out that here, for most of our interventions are for adolescents and young adults. And this makes sense because this is usually when substance use is initiated. But if we're talking about prevention, we should probably invest more here, because this is when we're already initiating. So it's a bit too late. So maybe our focus should be back here. Also importantly, notice the red and yellows. They're disproportionate when it comes to adolescents and young adults. So that means we're offering worse prevention for these groups. And lastly, when it comes to the universal strategies, that means what goes out to the entire population, this is where we're lacking evidence the most. So that would be, for instance, like campaigns, education, that kind of stuff. Okay, this report is going to be online quite soon. It's going to be really exciting to delve deeper into the data. Thank you.
Stay.